Okay, I think we're going to go ahead and get started. I know a lot of you have planes to catch. Well, I can't think of a better person to be closing this year's conference than Dr. Ross Brownson. Ross is professor of epidemiology at Washington University in St. Louis, where he investigates the impact of environmental and policy interventions on health behaviors. His accomplishments are many, and his biographical sketches in your program book, so I'm not going to go and read that in great detail. However, I do want to mention that Dr. Brownson is author of 6 books and over 280 peer-reviewed books. Articles, rather. He's prolific by any standards, but probably many of you don't know that he had also a career in public health before joining academia, where he worked for the Missouri Department of Health. And in that capacity, he wrote bills on tobacco access to minors, state clean indoor air, and private insurance coverage of screening mammography and Pap testing. He's truly been a trailblazer in dissemination implementation policy research, and we're incredibly fortunate, I think, to have him here to address this year's conference theme on policy and practice. So please join me in welcoming Dr. Ross Brownson.
So thanks, Helen, and thanks to Helen and the organizers for having me. It's great. It's a little perilous to close a conference between you and your airline flights, but thanks for hanging in there, and we'll try to make this interesting, fun, and save some time for some questions at the end. So I don't know the original origin of the quote, but you probably all heard the quote about, the 2 things you never want to see being made are legislation and sausage. And so apologies to any big sausage fans out there, but the reasons behind that are that it can both be kind of messy and a dirty process at times. So that's the focus of the talk, and to talk about that in the context of the broader D&I research that we're all vested in and interested in. So I'm going to try to cover 4 pieces in the next 35 to 40 minutes, and then save some time for questions. Very briefly understand the impact of policies on our daily lives. Look at least how we tend to define evidence-based policy, and briefly cover that. Think about some of the challenges and the opportunities that are out there, including some data from a couple of studies we're doing right now, and then hopefully pose just a few questions for you at the end, and that will hopefully get your own thinking going and then stimulate some discussion. This quote might be, and I guess that last one is, so if this is so important, why aren't we doing more? I think you heard Russ Glasgow mention this morning that we're not doing a lot of policy dissemination research, and I'll probably give you some of the reasons why I think that's happening. So if we look at the current occupant of the White House, I would say this is kind of what I take out of this quote. If you look at the idea of marketing and public relations and public opinion, this means President Obama buys into this idea of transdisciplinary D&I research. And so we've got a friend, hopefully, down the street at the White House looking at many intersecting forces. It's kind of a different way of looking at the idea of legislation and sausage making. If you think about this in your daily lives, think about, if you're coming to a conference in Bethesda, but if you were back home in your daily life, think about how policy has already affected you if you're going to work on a typical day. If you drive a car to work, you probably put on a seatbelt. That's a policy. If you go to an office building, there's probably no smoking in that building, and that's clean indoor air policy. If you get up and want to take a drink of water or brush your teeth, you can turn on the tap and there's clean water coming out. All those things are influenced by policy in a positive way. And then there probably are many that we would, if we really think about them, are influenced in not such a positive way. If you wanted to walk or bike to work, for example, it might be difficult to do that based on how local zoning is set up. Or you might go to a certain area of town and find it very hard to find healthy foods. And so those all are policy relevant. I probably don't need to spend a lot of time talking about the importance of policies, but one of my favorite little articles that came out around the time of the millennium was the 10 great achievements of public health that CDC produced. And I didn't put up all 10, but I put up a few examples. And every one of the 10, if you really dig into them, is influenced by policy. There's not a single one that doesn't have a policy connection. And here's a few that are clearly influenced by vaccination policy, motor vehicle safety, both in the design of the motor vehicles as well as policies governing driving, safer workplaces, occupational standards, fluoridation of water, and then, of course, tobacco use. And I'll come back to that one in a little later. And so these all involve policy in one way or another. In fact, another sort of crowning achievement of the last century of public health was that probably the largest gain in overall lifespan in any 100-year span in recorded human history. In the US, we gained 30 years of lifespan from the year 1900 to the year 2000 in 100 years. And so that is remarkable as well, and that is mostly due to public health and policy measures. To give you an example, what is a brief example here, a large-scale policy change. This is around tobacco. And so we see here the darker rates are basically high smoking states, and the light states are low smoking rates. And you see tremendous variation here in the United States around smoking rates. If you look at one example of policy based on a degree, at the time going into this, probably not a huge degree of knowledge about what would actually lower rates of smoking in California. This was California Prop 99, where in the late 1980s, the price of tobacco was raised by 25 cents a pack. The important part of this was that the tobacco proceeds were earmarked for a strong media component. Within about 5 years, we saw tobacco rates were already going down. We saw about a doubling of the rate of decline within a 5-year period, which is remarkable for a chronic disease risk factor. And then the last one, it was blend of science and soap opera. If you really know what was going on behind the scenes, there were a lot of interesting stories behind the scenes. We've seen other states now come on with Massachusetts, Florida, other examples where this has occurred. If you want to look at the progress here from direct policy measures, here's smoking rates in 1990 by regional variation in California. Red is a high smoking rate, green is a low smoking rate. Here's 1996, here's 1999, and then here's 2002. And so you can see the visual change. You often see maps like this when things are getting worse. Here's a case where things were actually getting better. The policy dissemination of this occurred through many different venues, but one was the CDC best practices, which was first published in 1999, which basically took the lessons from these policy measures more qualitatively and said, what should states do if they wanted to follow with California and Massachusetts and other states and what they've done? So out of this, I think, comes a few questions. When we look at data from researchers and they say, what should we do about policy dissemination? And we ask the same things from practitioners. They both say it's very important, and they both tend to say it's the other group's job. And so one of the fundamental questions for us as scientists as well as public health or medical practitioners is, whose job is it? Here are 3 recent articles that I pulled off of PubMed. One's about local tobacco control policy. Here's the suggestion from the researchers. We give you suggestions about how to use what we've learned in community settings. Doesn't mean we're going to do that, but we'll tell you how to do it. Here's surveillance. Here's how cancer control planners can use staged incidence and screening data. And so here's another recommendation about how practitioners could use the data. This one was a little more equivocal. This is looking at chemo prevention for diet and prostate cancer. Didn't show clear benefits from this, but patients can still be advised for other reasons. So in each of these, we've sort of tagged on a recommendation at the end of an article, but really probably haven't included the full policy translation as it goes forward. So I do think a fundamental question is, whose job is it, or whose job should it be, and who should fill that pipeline between discovery and application of policy? We can think about what it means. So the second part of this is understanding what an evidence-based approach really is. There are many definitions, and our group has developed longer definitions, but a simple definition is the one Neil Kahatsu published in 2004, which is science-based interventions, linking that with community preferences, of course, with the overall goal of improving health. For policy, it can be a little more messy, so here's the actual quote that we talk about, that we want to be sure of what's going on. And so we've taken sort of the broader evidence-based medicine and evidence-based public health concepts and have tried to apply them to evidence-based policy. And so we've looked, and this is not so different than the structural process and outcome issues you look at in the delivery of medical care, but we've broken it down into the process of policymaking, the content, and then the outcome. And so for a tobacco example, the process might be, how do you get stakeholders engaged? How do you get a coalition on board to be able to move forward with a California Prop 99 kind of an example? What happens? What happens when one of these doesn't work, as has happened in Colorado, Montana, and Missouri, and other states as well? So that would be process questions. If you want to put in a tobacco control policy, what are the evidence-based elements of that policy? What should a clean indoor air law include, or what should happen to the proceeds of a tobacco tax? And you could think about this for a variety of other policy measures. And then one that's probably done the least is, what are the impacts of that policy? And how do we measure those impacts? So another question that's worth thinking about is, what do policymakers need or want from researchers? And I think it's actually fairly simple. And think about this in your own work. The first one is, there a problem? Do we know what's causing the problem? For a scientist, that's an etiologic question. Do we know how to fix it? And I think that is an intervention issue. And so for those who do behavioral science interventions or policy intervention, that's another question. And then, how much is it going to cost us? We tend to think of sort of in cost-benefit analysis in public health or medical research, but for a policy question, it's often, what's the political cost? Is it going to cost me votes? Am I going to have a better chance of being reelected? Am I going to have resonance with the media when I put out this policy issue? And so we think about those, where we live, where we work, where we get elected if you're an elected official. And of course, we think about what the evidence is, and the evidence to some degree is in the eye of the beholder. A policymaker's evidence may be different than a researcher's evidence. So if you think about this, I like to think about the research policy nexus. And to illustrate this, I have what I call the fable of the balloonist, okay? So here we are. Anybody has ever been up in a balloon here? Yes? How about anyone who likes to go fishing? Yes? Okay, so we're going to combine those two elements in a little story. So here we are, maybe. Yeah. Here we go with the fisherman. Here's the balloon person coming by. And so what happens? Well, the person in the balloon says, "Where am I?" And down below it says, "You're 30 yards above the ground in a balloon." Okay, that makes sense. You must be a researcher. I am a researcher. How did you know? Because what you told me is absolutely correct, but completely useless. Okay? Does that ever happen? It does. You must be a policymaker. So we've got a quick-witted researcher down below. Says, "Yes, I am a policymaker. How did you know that?" Because you don't know where you are, you don't know where you're going, and now you're blaming me. So anyone who's worked across the policy arena can resonate with this, I think. A lot of my time in the health department was spent working with the legislature, and there is often a disconnect between the research world and the policy world. And so that's kind of a funny way of illustrating it, but I think it's very true. So if we want to try to connect up these two worlds, then what's the role for our work? And I'm just using the word dissemination research. I could use D&I research. I sort of shortened it up, and we could talk about definitions. But you all know about the classic curve that builds out of Ed Rogers' work, the classic diffusion curve. And we know this works pretty well when we've got voluntary decisions, when the innovation, in this case the policy in question, is perceived to be important, and then when we have adopters who have a social system where there's some control over the decision making, in this case, the translation of research to policy, okay? And that can include influence of opinion leaders, and so that opinion leader might be a key advocate in a community. It might be a legislator who gets the health issue and is advocating for it. And it often occurs through social pressures. When people go back and study movements, social movements, health movements. Obviously, diffusion theory grew out a lot from agricultural movements. This is how it works. I think a lot of the diffusion theory applies in policy, but there's also other theory, and I think if you're interested in this topic, you really need to dig into some of the other theories. I put one up here from Political Science from John Kingdon's excellent book. If you don't have that, I put the citation at the bottom. Kingdon talks about the three broad domains of policy, the problem, the policy, and the politics. Not so different than what we talk about with sort of process and content and outcomes. The important part of what Kingdon talks about are these windows of opportunity that open and close, and that when you're properly aligned with the three domains, you get policy change when you happen to be kind of in the right place at the right time when a window opens and closes. And I think this is an area that really should be more transdisciplinary, where we're learning across political science, economics, a variety of other disciplines. In the work we do, and I think a lot of what policy-related research, you have to remember that policymakers come in different flavors. There are big P policymakers, which is typically what we think about when we think about an elected official, someone elected to Congress, a state legislator, even a local city council or a mayor. That's kind of the big P in a democratic society. The small p we might not think about so much, but that's someone who controls resources in an agency, makes decisions about priority for, let's say, a cancer control program or a mental health screening program, or you name the condition or risk factor, who aren't elected. They might be appointed or hired into their job, but if they control priorities and resources, I would argue they're a policymaker. The other nuances to this can be the level at which a policy is operating. Is it a federal policy? Is it a state policy? Is it a local policy? For the issues you're interested in, what's the lever of influence that's most important? In the US, most of the control of public health tends to happen at the state level, but federal policy is very important, and for some public health issues, local policy is even more important. And then what about the setting? Are we talking about a broad community-wide policy? Are we talking about a school policy or a worksite policy? And so that's another layer on it. So there's at least 3 or 4 different dimensions to think about when you think about translation of science into policy, okay? What are we learning about the translation? Well, we probably know more, as I would say, in most areas of D&I research, about the barriers. So we know mostly about what doesn't work or some of the things we're up against. We did an article a few years ago that we called Researchers and Policymakers, Travelers in Parallel Universes. And the idea behind it was to think about the decision-making processes for researchers, those for policymakers, and then look for some areas where we might work together and do better. And this isn't the whole list, but just a few examples of the things on the list. The timing is different. A policymaker often has to make a decision in a very short period of time. What do you do when you write a research grant? You try to get your grant funded. It might take you a couple of years. You carry out your grant. That might take you 5 years. You get it published. You wait for the journal to get it out. That might take another year or 2. And so the pipeline is very long. And for many policy time-sensitive decisions, those time frames are very long and become irrelevant. We like to put all the cautions around our research, the p-values. Do we have a probability of less than 0.05 that we do or do not have an effect? Policymakers want to know, should I do this or not? It's more of a dichotomous variable without all the caveats. We have to balance objectivity and advocacy. And I'll come back to that in the last set of questions for you. But that is, if I get too much into this policy area, am I going to lose my objectivity, either the reality of my objectivity or the perceived objectivity? Maybe the data aren't relevant. If we've got an elected local official and we've got national data on some issue, they want data at the local level. And so we might not have the right data at the right time at the right geographic level. So that's something to think about as well. And then one of the most important I called the mismatch of randomized thinking with non-random problems. And that is that a lot of the policy questions we run into don't fit very well with random designs. And I'll illustrate that with another little example here. You're all familiar with evidence hierarchies, which are valuable when we evaluate the design of research studies, let's say in a systematic review or a narrative review. The question is about their relevance for policy. So another quote I like is the one from Voltaire. Let's not let the best be the enemy of the good. So how many people here have jumped out of an airplane with a parachute? Anyone? How many without a parachute? You wouldn't be here. Well, there's a nice spoof on evidence-based medicine that was in the British Medical Journal now about 6 or 7 years ago, I guess. And this looked at the use of parachutes and whether we need to go back and do a randomized trial of parachutes, basically. And of course, it's a spoof. It's trying to get us thinking about many things we do, especially things that are policy-relevant evidence, have not been subjected to a randomized trial, never will be, and probably shouldn't be. What we should be looking at here is linking up the research question we're trying to answer with the best possible design. If that happens to be a randomized design, that's great. Let's use the randomized design. But for many policy questions, that will not be a randomized design. And so it's important to think about that part of the equation as well. So the next little section here is to give you a few examples, I guess, from some of the work we're doing. And we're doing work with practitioners, with state-level policymakers, and now with some local policymakers as well. But this is going to be examples from our work with state policymakers. And this is one of the NCI D&I grants that are from the program announcement you've heard about here at the meeting that a lot of you already know about. The first part of this grant was to look at, so sort of the folklore or the common wisdom is that policymakers respond much better to a story than to the data. Have you heard that? So if you can tell a good story, you can convince a policymaker to do something, to introduce a bill, to support something. And we wanted to test that. So we decided to present information in a data format, typical data, scientific data summarized, still in a concise way, and a narrative format where you turn, it's not data free, but you're also including a narrative version of the presentation. And so we did so here's where you can do a randomized trial. We did a randomized trial with state legislators. And one of the underlying premises of the research is that, so if you look at what's often called a policy brief, it's often anything but brief. It's often pages long, sometimes a whole volume when you look at surveillance data. And so we wanted to do something that really was brief. And so this was basically one piece of paper folded. So it ended up being, I guess, four sides of a paper in a nice format where we're comparing a data presentation with a narrative presentation. And the brief we did was on mammography screening. So the usefulness of that, the scientific basis, what steps could be taken. And we have 4 groups of policymakers: state legislators, and I'll show you the 6 states, legislative staff members, who, if you've worked around legislative arenas, write a lot of the bills and actually do a lot of the policy work. And then leaders within health departments in the executive branch, that sort of small p policymaker that I mentioned earlier. And so what we were looking at is how they responded to a short questionnaire. And this is just the condition. So we had a data condition, a narrative condition, local data, and state data from these areas. We had a total of almost 300 people in the trial. Here are our 6 states. We had an overall response rate, not a great response rate for typical research studies. I would say that policymakers, especially the legislators, are very difficult to get to respond to a survey like this. I put it in the words like they have an unrealistic view of their own self-importance. Their time is very precious and they don't want to give it up. So it took some creative work, and we're trying to build on that as sort of the methods of getting policymakers to do this. So I'm going to give you just a couple snippets of data. These are these data classification trees, which basically are a visual exploratory way of looking at data that maximize the variance, and they're visual, so I thought it would be good for this presentation. This is the perceived usefulness of the brief among legislators, 74 legislators, and how it breaks. So if it breaks to the right, that's the higher usefulness value. So that's a value on a 5-point scale. These are all statistically significant. And you see this is actually branching the opposite direction of what we thought. The data-based version is branching first. The second branch on that right branch maximizes at Democrats, branched higher than Republicans by quite a large number. And then if you look down the story version, if you like story, then your second level is going to be you like the local data better than the state data. And these trees go on. I didn't put the full trees in here, but this gives us at least some exploratory data showing the branching. For the staff group, this is a little harder to read, but I'll just walk you through. The staff group here, this is the legislative staffers. Those without a graduate education branched first, and then women branched next, and then socially liberal individuals branched next. So you can see the branching there. And so if you kind of look across the board, when we looked at the branching of these briefs and what was useful, there were a few things that jumped out. Women looked like they branched better on a positive direction, so they responded better to the policy briefs overall. Those who were socially liberal, those who are older than 52 years, and those without a graduate education. So as we build on this, we're hoping this helps us basically create better communication materials for getting the word out on evidence-based policy for legislators. Another piece of this from this data collection that I wanted to show you was looking at what legislators view as the important factors that influences which health issues they choose to work on. And so see if you believe these data. So this is rank ordering, constituents' needs, effectiveness of scientific data, another data one, evidence of health impact on my local area, a local leader I trust, my personal interest, and then advocacy groups was the lowest one. So do you believe that? The second most, we didn't believe it either. And so there's probably some social desirability if a university asks a legislator how they make decisions, and we think that's probably partly at play. But we also ended up creating a new phase for our study where we went and interviewed members of health committees to try to dig deeper into what people mean by scientific information, where they get it, how they'll respond to it, because this first part was all quantitative. And so this is a little bit of qualitative data. We ask them what scientific evidence means to you. And here are a few of the quotes. Not much. It's thrown around. Science doesn't mean good science. I like the second one. I like to see things that are evidence-based and peer-reviewed. One of us could have said that. Science is the opposite of anecdotal evidence, so anecdotal evidence is what we rely on to make our decisions, unfortunately. So there's some honesty. They're actually telling us how they're making these decisions. So another little bit of data, where do you go? Here's a person that said they go to their constituents. That's their most trusted source. Here's one that said they go to the lobbyist. That's honest. Someone who goes to the internet. And remember, these are members of health committees. This is scary. Well, I have not. I don't think I ever thought I needed scientific evidence. So if anything, we're learning there's a range of opinions out there. And so the qualitative data is probably going to help us learn more about that and help us inform what we're doing going forward. And what we're doing now is working with a selected number of states, in a way sort of doing dissemination interventions to move their policy along based on these, what we call phase 1 and phase 1.5 of the original study. Okay? So let me end this part and leave time for questions, a few questions. There are many important questions for policy dissemination research, so I just put up enough that I could fit on one slide. One of the fundamental questions is probably, what is evidence-based policy? Is that a definable set of constructs? We're beginning to think not so much on evidence hierarchies, but evidence typologies, that we probably don't want it just evidence-based or not. There's probably a range of evidence-based that we want to think across, and we're using 4 domains now that we've now published. It's important to think about, especially for junior researchers and people starting out, is there low-hanging fruit? Is there something going on out there that I could study relatively easily? Are there data sets already available? This morning, I heard David Atkins talk about rapid response grants. A lot of the foundations actually do a better job of putting out rapid response grants than the federal government does, because they can turn things around more quickly than the federal government does with the necessary review processes. There's a lot of measures work that needs to be done. What are the realistic short-term, mid-term, and long-term outcomes for policy dissemination research? There's low-hanging fruit around dissemination of guidelines. there is a whole zillion of different guidelines out there. There's a lot of research that could be done about what's happening with those guidelines. How could we better study them, use active dissemination versus passive dissemination, and find out how it would actually change healthcare practice and public health practice. Here's a question: is it worth pursuing this line of research, or is it career suicide? Can I get this research funded? I think you can. It's not always going to be simple, and you're probably going to have some review groups that come back and say, why didn't you do a randomized trial of this study? But you have to keep at it, because you can make a case for the significance of policy research probably more easily than just about any other kind of research we do, because of the broad impact of it. What are some of the challenges that we're learning about if you're trying to do this kind of research? Well, response rates are one that we've run into, that it's sometimes hard to get a high response rate from policymakers. What do you like to do as a researcher? You like to control the independent variable. Sometimes very difficult to control the independent variable when you're doing policy research, so it's important to think about that. And then the social desirability of responses, depending on who's asking the question. This happens in all kinds of research, but might be particularly acute in policy research. What are we learning about that, and how can we minimize social desirability and get the most high-quality data possible? And then, at least in the world I live in, epidemiologic world, there's been quite a bit of debate about, can I be an epidemiologist and somewhere on the advocacy continuum, or do I become a wild-eyed advocate who will be seen as being so subjective in my research world? And I think there are ways to deal with that, and thinking more about a continuum of advocacy, not necessarily that you're always the one at the legislature testifying or writing the bill, but there's a whole continuum of how you can be involved. And I would argue that our role as scientists, we're obligated to be involved in somewhere along that continuum, not simply doing discovery work. Okay, and there's a lot of other questions, but that's a few anyway. I put up some resources, and I understand from Helen these will be posted, the slides, so there's many more. I just, again, put as many as I could put on one slide. And so you can see some from, the ones in the middle here come more from the public health world. The one at the top, the Bogenschneider book and the Kingdom work, come from other disciplines that can be helpful. I want to thank many people from whom I've stolen ideas over the years, and this is probably not a complete list, but in one way or another, this list of people have influenced my thinking on this topic, and I will say my thinking is evolving all the time, because it is, as I think Russ Glasgow alluded to this morning, it is a relatively new field, at least for this sort of area of D&I research, is bridging into policy research. And I thought this slide was the right one to leave you on for this talk. This maybe is for the whole seminar. It says, the latest research shows that we really should do something with all this research. And I think that's the fundamental reason why we're here, is to try to do something with research, whether you're a policy dissemination researcher or whether you're another kind of D&I researcher. That's kind of the fundamental issue, that we really ought to be doing something with all the new things we're discovering, not just discovering them for the sake of discovery. So that's it for the prepared remarks. Thanks, and I'll be glad to answer questions.
Hi, Marissa. Is this on? Oh, okay, there we go. Marissa Yanez with NIH. I'm actually a policy analyst with NIH, and I came across your program in some of the work that we do at the Office of the Director, and I was so fascinated by it. I read the paper, and I pulled all your references, and I brought it home. And in a couple conversations here and there, the topic of how is this research different from lobbying came up, because it seems like, I think some of the language from one of the papers was that one of the ways you were going to quantify the effectiveness was by surveying the uptake of policies that incorporate some of the latest findings from the policy briefs. And if you're looking at an uptake of policies, well, then how is that different from lobbying? So I would think that's one of the main issues that might come up in looking for funding for this kind of work. Has that come up, and how have you addressed that?
Yes, it's a good question, and actually we run into that when we write grants on this topic. So the way we usually separate it out is, if you think of Kingdon sort of problem, policy, politics, the way I think of it, at least, is the lobbying comes in the politics category, and so we stay away from that in the grants we write. Now, it doesn't mean that the results of your research might not be handed off to, the advocacy arm of the American Cancer Society. But what we're trying, and you could do research on advocacy as well, and people have done a lot of that in different areas of public health research. But I think you just have to draw the line somewhere that you're doing research, and you can document it through research that you're not getting involved any direct way in lobbying. But it's a fine line, and I know of some early grants in the tobacco area that really got dinged because they looked too far over here to be advocacy grants. And I think it's always focusing on what the research questions are. But it's sort of a fine line. It's a little tricky for this area. Yes, Alan.
Alan Best, the InSource Research Group in Vancouver, Canada. Thanks very much, Ross, for an excellent presentation and starting this dialogue about how we can get more involved with decision makers. I want to comment on your suggestion that they're basically asking the three questions of what's the problem, can they fix it, and what's the cost. All true, but yesterday Leif Solberg talked about a more co-production or a collaborative participatory model of researchers working directly with the policymakers to answer the questions they want. And our experience is that when you start doing that, you can be more optimistic in some ways about the questions that they're going to ask. The next question they ask after they've answered those, because they do have to answer those, is how much grief is it going to cost me? Yeah. And that's largely around how much am I going to have to change the system or the way we work to get this innovation in there? And obviously they weigh the cost, but ultimately, in our experience at least, that leads them to the final question perhaps, which is how important is this in terms of doing the right thing to have a population impact? And increasingly, I think, policymakers are willing to come to that last question if you work collaboratively with them through the process. Your experience too, would you encourage us to start working more directly with policymakers? Yeah,
I definitely agree with that, and I think that you end up, I think, with policymakers, much like with other dissemination questions where you have the early adopters. And if you find those early adopter policymakers or the maybe early to mid adopters, those are the ones that I think are ready for that kind of a dialogue. And I think that can be very useful, especially if that happens to be the party in power or the opinion leaders or the other sort of entities that we know lead toward more effective dissemination. And so I do think, and that's actually what the Bogenschneider group in Wisconsin, they have these regular, what they call them, family health seminars, which are basically dialogues with legislators around family health. And they've had good success with that. So I think, and that often is more qualitative, and part of that is having legislators get to know and trust researchers to listen to them. There's some of the other comments that we got from sort of finding scientific evidence from legislators. They said, there's so much thrown to us all the time, we don't even know who to call when we have a question to do. So they're looking more for like a one-stop shop of how we can get our question answered on the latest evidence when, there's basically a health story every day out that you could put somehow into policy. But I think it's a great point. David.
Ross, great talk. I was struck by how similar your work with, real policymakers, elected officials, is similar to working within a health system with people who are setting, clinical policy. And I guess with the exception that they aren't, subject to vote every 2 years, that they have the same kinds of issues. And my, so I guess one question is, are there other distinctions there that I'm missing? But then the second question, drawing from our experience with sort of clinical policymakers in a health system, is that one, it is about relationship building, and so that they depend more on a relationship that they've come to trust and value than on sort of quantitative data you can give them. And then second is, and I think I stole this from sort of Jonathan Lomas, who had a slide where he sort of talked about white and black and gray areas, and that there's sort of a sweet spot of identifying issues where there is some, I'd call decisional equipoise, where a policymaker actually is willing to be swayed one way or the other. And Jonathan Lomas's point is we don't want to spend our time convincing a legislator that what they think is white or black is gray, because that doesn't help them. But there are some areas where they think it's gray, and if you can help them say it's white or black, that's useful. And so in a health system context, there's some things that the health system is going to decide to do and because of a variety of factors, and trying to influence that may not be, but there are other things where they really haven't yet decided what to do, and then figuring out where research can reach them. And I guess that, I don't know if that's a question or a statement. I mean, there's a risk in that maybe we don't want to surrender everything. You know, if they've decided to do something that we really don't think is right, we need to sort of think about when there's an opportunity to sort of have them revisit that decision.
Yeah, I think that's a great point. Yeah, I think they're all great points. I think the sort of the differences in a health system and maybe in a body of elected officials could be that you tend to get people who already know about health in a health system, and so I think we might have a little longer learning curve if you've got someone who might be a businessman who's now elected in the Speaker of the House or some other legislative leader. But I think many of the organizational challenges, the relationship building, the ideas of trust and respect that are needed in the process layer out the same. And I think the other point about sort of looking for the gray areas, what we're trying to do a little bit more is not say, here is the one policy alternative, but provide a range of evidence-based alternatives. So those in the gray area that could be moved don't say, I have to do this or that, but there's a range of options. And I think some of that would apply in health systems as well. But I do think the comparative work of sort of saying the traditional policy area and policy of health systems and policies of other organizations who influence health need to be looked at sort of across.
And I guess the one last comment, I didn't see anything in there, sort of the equivalent of opinion leaders.
Yeah.
I mean, do you find that also exists in the health policy arena, that there are certain colleagues that the legislators kind of look to, and if you can get that person, then you can really start to influence the other people?
Yes, and it's mostly qualitative, but there's clearly qualitative research that the typical opinion leaders that you learn about in dissemination science, diffusion science apply in the policy arena as well. Good.
Last question.
Oh, thank you.
Okay.
I'm Margot Krause. I'm an epidemiologist and also a retired Army public health physician. And I thought your talk was fascinating. It made me think a lot. And I guess it's more of a comment than a question for you, because in my 20-some years of working in public health within the military system, and seeing the civilian system, I just noticed some very interesting things. Because I think everything is actually personal. As you showed in your mammogram existence, I mean, the fact that females are more interested, yeah. Who else cares about mammograms? Yep. So we can't forget the people. They're not just policymakers, but they're people. All of it is very personal. And as I reflect back on the HIV epidemic, the military got a lot of criticism for doing contact tracing. I mean, it's standard public health, but it was very political. The civilians didn't want to touch it. Military, we don't care, we just do it the way we always done public health. So after about 15 years of great criticism, now the civilians have done the same thing. So everything is political also in public health. So I do have some concern about researchers getting into this politically charged, personally charged endeavor, because even as researchers, we still bring our personal political background to our research. And I know mammogram is a great example because there's been a lot of political angst over the whole thing. When I was saying what they recently came up with 20 years ago, I was basically told, yes, that's scientifically correct, but it's just not good for public relations.
Yeah.
You know, so we have to do this. And I said, okay, fine. As long as you understand, I could be the scientific advisor to the commander, but I'm not going to make policy. The commander is. So I guess it's just a caution. I think I would go on more the side that we should be scientists, we should do the best we can, but also recognize we have to be very humble because evidence does change.
Yeah,
So.
and I think some of the obligation of a scientist may not be that the scientist is the advocate, but it's who do you hand that off to if you've got a finding or a systematic review, a body of literature that's ready for action in some ways. who can take that action. It doesn't mean you have to do it all, but it has to see what that pipeline is, so that the pipeline doesn't just end with discovery of new knowledge and then stops there. And so I think that's kind of the fundamental part.
Thank you very
Thanks.
much for your talk. It was
Thank
great.
you.
Please join me in thanking Dr. Brownson again. Thanks, that was wonderful. I know everybody's anxious to get going, but please fill out your evaluations. We really do read them and try to take your input into account for planning next year's conference. So your ideas are more than welcome. Thanks.
Okay.